Vamos a comenzar para no retrasar la sesión y que luego nos incorporemos tarde a nuestra rutina. Primera sesión de la temporada de Santander Biomedical Lectures de Lidival, que nos da la oportunidad de hacer hospital y jefatura para tener esta sesión los jueves, el último jueves de cada mes. Hoy hemos invitado a James Hutchinson. James es un inmunólogo, es británico, pero lleva ya... How many years have you been to 17? En Regensburg. Está trabajando en Alemania desde hace 17 años y él es británico, se formó, trabajó en Cambridge, es inmunólogo con el que nosotros, el servicio de inmunología, el grupo de inmunología ha colaborado. De hecho, tuvimos una chica ahí haciendo una estancia y hemos hecho ciertas colaboraciones, sobre todo en trasplante. Pero James se dedica al trasplante y a otras muchas cosas. Él trabaja en inmunorregulación en general y ha estado trabajando mucho en células dendríticas reguladoras y lo que induce. Y parte de ese trabajo también tiene una traslación, una transferencia, y un ejemplo claro es la sesión que viene a hablar hoy. Él va a hablar hoy de Photopheresis extracorpórea, ¿vale? Y el papel y las utilidades que tiene en trasplante. Es una actividad que ya se hace aquí, que el servicio de hematología por la unidad de transfusión ya lo lleva haciendo tiempo, lo hace en una serie de situaciones y podemos tener... y un poco nos lo va a explicar ahora aquí James. Quisiera también resaltar, antes de la charla, el papel que tiene James como, aparte de sus muchas publicaciones y proyectos, es muy activo en el reclutamiento de gente joven y en la enseñanza de gente que quiere investigar, y él es el líder, lleva ya 2 programas europeos liderando de la iniciativa Instruct. Instruct es un grupo de gente interesada en lo que es inmunorregulación. Y en este caso, en el momento actual, está trabajando en una línea que tiene que ver con generación de células mieloides reguladoras. Forman un consorcio europeo en que hay grupos españoles. Uno de los motivos por los que está aquí es que también buscamos colaboraciones para nosotros entrar dentro de ese consorcio, ¿vale? Sabéis que tenemos que ir a Europa y él está trabajando mucho activamente en eso y en la búsqueda de biomarcadores en otra situación que es también un poco distinto, y todo esto lo introduzco porque en la audiencia puede haber gente que puede estar interesada luego en acercarse y hablar con él y con nosotros. Por ejemplo, en hígado graso acaban de publicar cosas muy interesantes de biomarcadores para el manejo de la esteatohepatitis, y es una línea de trabajo que también está muy interesado en potenciar y en desarrollar, tanto desde allí y en colaboraciones con colegas como podemos ser los que estamos aquí trabajando en Valdecilla. Y sin más, James, thank you very much for coming to Santander and to share with us what you know about extracorporeal photopheresis.
So, good morning. Thank you, Marcus, for this very kind introduction and for welcoming me to your very beautiful city. As Marcus said, the reason for coming to Santander for me at this time was to involve Marcus in a new consortium that's just been funded by the EU, which is focusing on the use of extracorporeal photopheresis to address unmet needs in transplantation. So what I intend to do in the next 30-35 minutes is give you a very general introduction into extracorporeal photopheresis and its potential uses in transplantation. And I'll try to avoid going very deep into immunological mechanisms. First of all, for those of you who aren't so involved in transplantation, I think the mechanisms that we are now talking about are very general, in fact. In transplantation, we're really talking about how to control the cycle of orderly inflammation. And so let's think, first of all, about what the challenges are that we face in modern organ transplantation. Before the donor dies or the organ is explanted from a living donor, the tissue is in a normal homeostatic state, and I mean physiologically homeostatic and also immunologically homeostatic, because in all tissues you have regulatory immune mechanisms that are necessary for maintaining an absence of inflammation. But that all changes very abruptly when the donor dies. Even brain death is sufficient to change the immunological homeostasis in tissues generally. And particularly when we deprive the organ of its blood supply, we induce damage to the tissue, ischemic damage, and then reperfusion injury when the organ is revascularized. And then that injury is compounded by the very rapid influx of alloreactive T cells into transplanted organs that contribute to this early inflammatory injury. And that inflammatory cascade particularly initiates the early infiltration of monocytes into transplanted tissues that enter the graft and then differentiate into activated macrophages, and they cause tissue damage. And we call this process acute cellular rejection. And normally it would lead to the loss of a graft within a few days, except that modern immunosuppression is incredibly efficient in preventing acute rejection. So the use of calcineurin inhibitors, antimetabolites, and steroids. The drawback with that regimen, of course, is that it's very nephrotoxic and it increases the risk of infection early on. And that presents a problem particularly for us in liver transplantation, but also in cardiac transplantation. If you can get the organ through this early phase of immunological injury, it enters a phase of resolution and repair that's characterized by a change in the population of macrophages in the tissue. They switch from this activated inflammatory form to an immunosuppressive, immunoreparatory form of macrophages. And that's important because those macrophages take up necrotic material and dispose of it. They produce trophic factors to get the parenchymal cells to grow. They secrete factors to revascularize the organ. And they suppress an ongoing T-cell response within the graft itself. Of course, what we would like is for that organ then to return back to a state of normal immune homeostasis so that the graft can be accepted long term. But actually, the more usual outcome is that we end up in a state of non-resolving inflammation. And this is how most grafts nowadays are lost. So the average half-life of a transplanted kidney now is about 11 years. And they're lost through chronic damage, through fibrosis, and then subsequently the formation of donor-specific antibodies, new donor-specific antibodies. And that leads to further vascular and parenchymal cell damage and ultimately the gradual loss of the graft, which we call chronic rejection. So my interest as an immunologist is in this switch. How do we decide whether we go into a state of non-resolving inflammation and how do we switch back to normal homeostasis? And what we think is that you need a third population of macrophages at this point, called the regulatory macrophage, that's responsible for re-establishing homeostasis. Okay. To the theme of our consortium and the rest of this talk. Extracorporeal photopheresis is a very long established aphoretic therapeutic procedure. And for those of you who don't know about it, the process is that you take peripheral blood from your patient, you perform an apheresis to concentrate the leukocytes and plasma, and you return the red blood cells and platelets back to the patient. Then you take your concentrated leukocytes and you treat them with a DNA intercalating agent called 8-methoxysorolene. This integrates into DNA, and then when you UVA irradiate these cells, you cause double-stranded DNA breaks in the leukocytes, and that induces those leukocytes to go into apoptosis. And at that point, you return the product of this process, which we call the photopheresis, back to the patient. So in this process, what you're doing is many things to these cells. You're inducing cell death through the application of 8-MOP and UVA, but also the cells come into contact with plastic surfaces, which induces platelet and leukocyte activation. It also leads to the release of particles and soluble factors from cells in blood. You put the cells under mechanical stress, and you obviously have to expose the patient to anticoagulants, usually citrate, but also possibly heparin. So you're doing a lot to the patient that is potentially immunologically active. Nevertheless, this is a long-established and safe therapy. It was initially introduced for the treatment of cutaneous T-cell lymphoma, and the idea was that you could debulk the tumour from peripheral blood by taking the cells out, killing them, and returning the red blood cells and platelets to the patients. But it was subsequently used as a with this idea of lymphodepletion in mind. It was then used as an immunosuppressive therapy, let's say. So it was shown to be useful in the treatment of graft versus host disease. More recently, we've been using it in the treatment of checkpoint inhibitor-induced complications. But in this context today, it's a long-established guideline technique for the treatment and prevention of heart and lung transplant rejection. More specifically, in lung transplant rejection, it's indicated as a way of slowing the progression of bronchiolitis obliterans syndrome. But now there's very exciting data coming out of Vienna that suggests that if you apply extracorporeal photopheresis as an add-on therapy immediately after transplantation as a prophylaxis, it greatly reduces the rate of infections, acute rejections, and the number of patients who subsequently develop CLAD. It's also used in heart transplantation for the treatment and prevention of acute and chronic cellular and antibody-mediated rejection. And although it's gained traction in cardiothoracic transplantation, its application to abdominal transplantation has been much slower. And one of the questions that we're asking within the consortium is, why is that? Obviously, there are practical hurdles to introducing ECP in wider practice. It's an outpatient procedure, so you need to bring patients in usually twice a week for several months. But there are also a lack of consensus guidelines for how you would go about treating kidney or liver transplant recipients. And I think critically, there's really a lack of understanding of the immunological actions of ECP in transplant recipients. There's a lack of reliable clinical tests for potency or efficacy, and we can't, on a patient-by-patient basis, predict what the benefit to the patient will be. So one of our objectives within the consortium is to better define which are the important immunological actions of ECP in transplantation, and to find, for instance, biomarkers that would help guide clinicians through therapy decisions with ECP. Which patients should get ECP for how long? So why do we think ECP might work in organ transplantation? Well, I think at the beginning it's important to say that there is no one single therapeutic mechanism. I've already told you that these photopheresates are very complicated immunological products. But it's also worth noting that transplant injury is caused by many diverse immunological processes, and it's possible that ECP affects different pathological processes in different contexts. And so what we have to ask ourselves are, what effects of ECP are most relevant to the specific pathology that we're dealing with at the time? Antibody versus cell-mediated rejection, for example. And we can get clues about the mechanisms of ECP in different ways. So we can look at established indications outside transplantation and ask what kind of diseases is ECP useful for treating. We can also look at the composition of photopheresates and look at each individual component and say, what are the immunological effects of this component? And then we can also look at immunological changes that we see in patients before and after ECP, and then infer what ECP might be doing. So what are the current clinical applications of ECP? Well, it's very widely used in the treatment of acute GVHD. That's the main indication at our clinic. But it's also been successfully used in the treatment of atopic dermatitis. It's been used in Crohn's disease. And recently, it's been shown to be very useful in the management of checkpoint blockade induced treatment-resistant colitis. There's a curious aspect of ECP. So although it suppresses T cell responses responsible for GVH or dermatitis or Crohn's disease, it has an unusual effect in that it also primes cytotoxic T cell responses against tumour antigens. And this has been shown in the context of the treatment of cutaneous T cell lymphoma, because actually the therapy for CTCL works much better than you would expect for a simple debulking therapy. And what the Adelson group in New York showed was that if you apply ECP to CTCL patients, you increase the frequency of tumour-specific T cells in peripheral blood. And so it looks like rather than suppressing the immune response to CTCL, you enhance it through ECP. The other thing is that ECP is very good at preserving protective immune responses, and particularly preserves, for instance, important in the context of transplantation, protective immunity against CMV. There are a lot of groups now, including the kidney transplant group in Barcelona, who are very interested in the use of ECP for the treatment or management of antibody-mediated kidney transplant rejection. It's established as a therapy for heart and lung graft rejection, but now that's clearly been extended by the group in Barcelona to kidney. Interestingly, it's not so. Although we see with ECP a reduction in the amount of circulating anti-donor antibody, we also see a preservation of anti-CMV antibody, for example, and other protective antibodies. And the interesting thing is that ECP doesn't seem to be a good therapy for treating classic autoimmune antibody-mediated diseases. So it's ineffective, for instance, in myasthenia gravis. So this is a contradiction that we have to try to explain. ECP also seems to have benefits in fibrotic diseases, very clearly in bronchiolitis obliterans syndrome after lung transplant, but it's also been applied in systemic sclerosis with some success. Okay, what is a photopheresis? Well, if we can break this down into three major components, right? First of all, there's the dead or dying cell component of the photopheresis, which comprises apoptotic or pre-apoptotic or necrotic leukocytes. And then we also have subcellular fragments of those cells, including very small membrane-bound particles. There's also secondarily possibly a living cell component of photopheresis, which might include modified monocytes in particular. And there's an acellular component. So when you put cells through this kind of process, you release a lot of cell-derived mediators. So, for example, apoptotic T cells generate massive amounts of TGF-beta, which is a very suppressive cytokine. But they also release other cellular constituents that can have inflammatory effects or anti-inflammatory effects. For instance, HMGB1, which is a TLR4 ligand. In addition, through this process, we get modified serum proteins and the release of immunologically active metabolic products. And all of these things are returned to the patient with the photopheresis. Okay. So now I'd like to remind you of a very important immunological mechanism. This is the mechanism by which we maintain constitutive peripheral self-tolerance. So in this mechanism that was first described by Ralph Steinman, what happens is you have a pool of dendritic cells in all normal tissues. And in the absence of inflammation, those dendritic cells constitutively take up self-antigens from their environment and then migrate in a semi-matured state to local draining lymph nodes, where instead of activating immune responses, they're responsible for preventing T cell responses. So if a dendritic cell takes up material from an apoptotic parenchymal cell and transports it to the lymph node, you delete self-reactive T cells, and it helps maintain the peripheral population of regulatory T cells. And I think this is the main mechanism that ECP is hijacking as a therapeutic principle, because we're supplying apoptotic cell material to dendritic cells in a non-inflammatory context. This principle has been exploited many times in transplantation research. So we know that if you take a mouse heart transplant model across a full MHC mismatch and you apply apoptotic splenocytes in this context before the transplant happens, you can achieve full immunological tolerance of that heart graft. Importantly, if you delete macrophages and or dendritic cells between the apoptotic cell therapy and the time when you give the transplant, using things like CD11C, DTR mice, what you find is that you then can't establish tolerance to the allograft. And what this research has shown is that the effect, the protective effect for the graft is mediated by macrophages in the red pulp and CD8 alpha positive dendritic cells in the marginal zones. And we now know in molecular detail how this kind of effect is achieved. Apoptotic or secondarily necrotic cells are recognized by a whole raft of different pattern recognition receptors expressed by myeloid antigen presenting cells, so that's dendritic cells and macrophages. And the net consequence of signaling through these kind of receptors is that you get a downregulation of T-cell stimulatory and pro-inflammatory factors, and instead you upregulate anti-inflammatory and checkpoint-related factors, so TGF-beta, IL-10, PD-1, IDO. And the functional consequence of that is three things. The first is that these antigen-presenting cells are able to induce abortive activation of CD4 T cells. So the T cells recognizing those dendritic cells will die. It leads to induction or support of natural proliferation of natural Tregs. And the third thing is enhanced cross-presentation of antigens. Now, for those of you that don't know, cross-presentation of antigens is the process by which antigens are taken up exogenously and presented in the context of MHC class 1, so that they are presented as CD8 T cells instead of CD4 T cells. So this might be part of the explanation for how we get a priming effect as well as a suppressive effect through apoptotic cell induced antigen presenting cells. So ECP requires that you have dendritic cells in the photopheresate. This was shown very nicely a long time ago by Tom Schwarz's group. They were using a contact hypersensitivity model in which they applied a hapten to the skin of mice. And then they were taking splenocytes that they performed an ECP-like procedure on and transferring that into a new mouse. And what they showed was that with this ECP-like treatment, you prevented the development of contact hypersensitivity. Crucially, what they showed was in this second mouse that was unable to get contact hypersensitivity, if you isolated regulatory T cells from those mice and transferred them into a third mouse, you also transferred the protection against contact hypersensitivity. So this is an active regulation that's induced. And what they further showed was that if you deplete the original preparation of CD11C dendritic cells before you treated a mouse, then you got contact hypersensitivity. And the interpretation of this experiment was that you need something like CD11C dendritic cells in the photopheresis in order to have the therapeutic effect. It's subsequently been worked out the mechanism by which you can ECP induces a kind of suppressive monocyte within ECP products. So as blood flows through this extracorporeal circuit, what we find is that there's fibrin deposition on the plasticware and plates. And that leads to adhesion of platelets. And the platelets are activated and express P-selectin, which is recognized by a receptor on monocytes called PSGL1. And that leads to the suppressive differentiation of monocytes. And it's claimed that these cells are capable of cross-presenting tumor antigens to CD8 T cells, but they also have a CD4 T cell suppressive capacity. And that led to the idea that ECP is in fact a cell therapy, and the important thing is the living cells within the product. But that's not consistent with other experiments where it's been shown that what in fact you need is dendritic cells from the recipient to mediate this effect. So this is a complicated mouse experiment, but we'll do it very quickly. If you treat a mouse with autologous dendritic cells and then give it a heart transplant, for, a fully mismatched heart transplant, you get rejection, as you would expect. If you pulse those therapeutic dendritic cells with donor peptide before you transfer them in, then that mouse will become tolerant. The important thing is that if you, at the same time as transferring in those therapeutic dendritic cells, you deplete all of the dendritic cells that were present in the mouse before, then you get no therapeutic effect. And the interpretation of this experiment is that you need the therapeutic dendritic cell that you've transferred into the animal, but you also need the recipient dendritic cells in the animal, which mediate the effect. So what we think is going on, there are three possibilities. It may be that within your photopheresis you have apoptotic cells, and they modify recipient dendritic cells, which then modify the recipient T cell population. The second possibility is that somehow you have these monocytes arise in the photopheresis, they engraft in the recipient and modify the recipient T cells. But the third possibility, the one that I think is true, is that you have ECP modified monocytes that are dying but not dead. And that's important because they have the capacity to migrate to places, lymph nodes or the spleen, where they can die in a sort of self-conditioned anti-inflammatory environment and give up antigens to recipient dendritic cells. And it's the recipient dendritic cells that are then responsible for modifying the recipient T cell response. Okay, how can we use these immunological effects in the clinic? One possibility is to avoid the need for high-dose immunosuppression, and that can be done in three contexts. First of all, in terms of avoiding early nephrotoxicity or infectious risk in transplant recipients. It can be done in terms of supporting immunosuppressant reduction while we're treating infectious diseases or malignancies. And it might be useful in the long-term minimization of maintenance immunosuppression. So there was a very nice study done in Vienna looking at high-risk heart transplant recipients. These are patients who were on ECMO for a long period prior to transplantation or had pre-existing malignancies. In these 28 patients, they performed add-on ECP therapy, 2 cycles a week for the first 2 weeks, and then subsequently 2 cycles a month up until 3 months. And they introduced an early CNI delay so that the patients were at lower risk of infections, and they had very nice results. They had an excellent 1-year survival rate. They had a very low rate of biopsy-confirmed acute rejection. And importantly, the 1-year cancer recurrence was low, and they had very few severe infections. So this is a case where ECP has replaced early immunosuppression to the benefit of an at-risk transplant population. And we would like to now do the same thing in the context of liver transplantation, because in Germany we allocate livers to patients in greatest need, i.e. those with the highest MELD score. And we have a problem with patients who have pre-existing renal impairment, and the early introduction of CNIs in those patients often leads to chronic renal failure problems in up to 60% of our patients. And so at the moment we have a schedule of that we call bottom-up immunosuppression, where we delay the introduction of CNI or sirolimus for as long as possible, and we only introduce it when the liver function tests start to go off. So we essentially wait for rejection before treating. This is very successful in terms of maintaining renal function in those patients, and the overall 1-year survival is very good. The problem is we have, of course, a very high rate of acute rejection. So what we would like to be able to do in these patients now is introduce ECP as an add-on therapy to try and reduce the rate of early rejection while still avoiding early use of CNI or mTOR inhibitor. The second place where ECP is used quite a lot in transplantation is when we need to treat infections or malignancies, so particularly PTLD. It was, as I've already described, it's been shown in CTCL that ECP can induce CTL responses against tumour, leading to this idea of it being like a vaccine therapy. And there's also the possibility that ECP has a mild lymphodepleting effect, which could also enhance anti-tumour responses. ECP has been shown to be a useful add-on when you're reducing CNIs during the treatment of CMV, of polyomavirus, and more recently in treating COVID. And it's been shown in the context of HIV that if you introduce ECP, you can increase the frequency of anti-HIV specific T cells. It's also now been used quite in many cases of PTLD when a reduction in immunosuppression is necessary. In particular, the publication from Augusto looked at 3 cases of PTLD after kidney transplantation when immunosuppression reduction for treatment of PTLD led to acute cellular and humoral rejection. Those patients were then started on ECP without increasing CNI treatment, and that led to a resolution of the acute rejection, a suppression of the DSA, and no recurrence of PTLD. The other thing I've already explained, I think, is that ECP can lead to the induction of regulatory immune mechanisms. And what we think in general is that regulation can be used as a substitute for immunosuppression. So normally we have patients with high effector responses, low regulation, and they need a lot of immunosuppression. But there's an additive effect of those immunosuppression and regulation, such that if you have a very high, very strong regulatory response, those patients need less immunosuppression. And that's a concept that we use all the time in biomarker-guided studies, and including immunosuppressive therapies, like the one study that we were involved in. So this is a kidney transplant trial, and one of the cell therapy trials I ran at Regensburg, where we treated patients with cell therapy products in order to minimize immunosuppression and ultimately take kidney transplant recipients down to low-dose tacrolimus monotherapy, which we were able to do in about 40% of the patients. We had similar rates of rejection in the treated and untreated patient cohorts. But the important thing was when we were able to safely reduce immunosuppression in the cell therapy treated patients, we saw many, many fewer infections. So in blue, the cell therapy group on low immunosuppression, in red, the standard therapy, triple therapy group. What we saw were many fewer viral infections, and in particular we saw many fewer CMV infections and polyomavirus infections. So there is potentially a benefit of inducing immune regulation against donor in kidney transplant recipients in terms of reducing the acute rejection rate and through reducing immunosuppression to getting fewer infections. How are we doing for time? 5 minutes. So very quickly, this is how anti-donor responses are anti-donor antibody responses are normally generated. What happens is that donor antigen is taken up by follicular dendritic cells that sequester it on their surface and present it to naive B cells. B cells become activated. In parallel, the same antigens taken up by myeloid dendritic cells are processed and presented to T cells. The activated T cells and B cells migrate together to the borders of B and T cell areas and engage in cognate interactions that leads to the further activation of B cells, which can have 3 consequences. One is the generation of short-lived antibody-secreting cells. One is the formation of pre-GC memory B cells. And the third is that those B cells enter a germinal center reaction where they undergo somatic hypermutation and selection to produce, and isotype switching to produce stronger antibody responses. And after exiting that germinal center reaction, they can become memory B cells or plasma cells. The important thing here is that the post-GC antibody-producing populations are much less T-cell dependent than the earlier forms. And this is perhaps how ECP is having its effect on the amount of DSA, de novo DSA, that we see in kidney transplant recipients. So it might be that ECP is suppressing myeloid dendritic cells in the same way that I've already described, and therefore depriving B cells of T-cell help. It's possible that ECP does the same thing to follicular dendritic cells. It may be that the myeloid dendritic cells, in the same way that they generate conventional Tregs, could also be generating T follicular regulatory cells. It's something that we don't know and will be investigated within the extra consortium. And it may be that we're generating more B-regs. But the total consequence of this is that you can suppress the T-cell dependent early production of DSA, but what you can't do is suppress antibody production from long-lived plasma cells in the bone marrow. And that's important because this explains how maybe you could suppress new donor-specific antibody but preserve protective antibody responses, for instance, against CMV. I've told you that ECP has an antifibrotic effect, and this is very important for the treatment of bronchiolitis obliterans syndrome. That was established a long time ago by trials in Vienna, and I've told you now that the Vienna group have shown that there's a benefit to prophylactic ECP in lung transplant recipients. But the way that ECP prevents or reduces fibrosis was really not well understood. It could have been an effect through T-cell suppression of T-cell mediated responses or suppression of donor-specific antibody, but there was always a question whether it had an a specific antifibrotic effect. And in fact it does. And there was a very nice paper published recently in JCI by a group from Washington. And they showed in this mouse model that ECP has the potential to directly downregulate peribronchial inflammation in a bronchiolitis obliterans model in mice. And ultimately what they demonstrated was that it was because apoptotic cells interact with alveolar macrophages to induce them to express a protein called decorin. And decorin is a natural antagonist of TGF-beta. And by suppressing the bioactivity of TGF-beta, you can reduce the fibrosis in this model. So this is a direct antifibrotic mechanism that doesn't require T cells. So let's summarize everything. Graft antigens, donor alloantigens, are normally taken up by macrophages and dendritic cells in lymphoid tissues. If you treat with ECP, those dendritic cells and macrophages are also exposed to apoptotic and pre-apoptotic cells from the photopheresate. And the consequence of that is those dendritic cells suppress and regulate alloreactive CD4 T cells. Because you're limiting T cell help to B cell differentiation, you can attenuate T cell dependent antibody responses and the formation of donor-specific antibody. And both the suppression of T cells and antibody production can prevent graft fibrosis. Additionally, now there's data that shows that apoptotic or pre-apoptotic cells from photopheresates can directly prevent graft fibrosis. So these very exciting mechanisms are now available for us to exploit in new indications of ECP in solid organ transplantation. And I think we should end there and answer some questions.
Sí, este sí se oye, ¿no? Okay, thank you very much, James, for trying to explain in a simple way. It's so complicated, the mechanism. I don't know if there is any question. Yes, Dr. Ramon, from our Photopheresis unit.
Thank you very much for your talk. De cara al hospital, pues que llevamos desde el 2008 haciendo fotoféresis. Quiero decir que tenemos ya cierta trayectoria en hacer esto. Por eso a mí me resulta particularmente interesante esta charla y me gusta que se haya dado porque, digamos, pone en relieve pues que tenemos cosas para hacer para los pacientes. Quizás no lo usamos con mucho entusiasmo la fotoféresis, pero bueno, que yo creo que esto puede abrir el debate de si necesitamos utilizarla más y no esperar un poco como último recurso, ¿no? A ver cómo, digamos, cuando ya hemos agotado todas las balas, pues utilizamos esta y ya quizás pues los pacientes no se puedan beneficiar tanto. Entonces quizás esta es una muy buena ocasión pues para a partir de aquí empezar a pues quizás elaborar otra vez más la estrategia con los pacientes trasplantados de órgano sólido. My question was, is that we don't actually know how this works, or there are a lot of mechanisms that justify that how ECP works, but do you think there could be different biomarkers for different organ transplantation models, or should we use the same? And if there are, how far are we from finding those mechanisms or those biomarkers that could help us, you know, tailor the strategy for each organ transplantation and for each single patient?
I mean, I think that's a really important question, and this is why the EU has just funded our new consortium, which Marcus will be joining, which is called Extra. And I think for each of these new potential indications, you know, suppression of T-cell mediated immunity and generation of regulation, for the control of transplant fibrosis, for the induction of CTL responses, we're going to need different biomarkers to guide each of these therapies. So it's going to be very much a personalized approach, but that's always where ECP has fitted into solid organ transplantation, I think, as a almost as like a therapy of last resort in many cases. And I think we need to get through that phase before we can start to introduce it more generally as a general kind of prophylactic therapy. So yeah, I agree. We need a variety of different biomarkers for different transplant pathologies.
Thank you very much for your nice presentation. I had two questions. The first one is, we frequently use thymoglobulin, lymphocyte depleting antibodies, in order to induce a reduction in the leukocyte count and the immune response. Can this treatment before photopheresis influence the effect of photopheresis, or does it have any influence on the response to photopheresis?
Thymoglobulin, it's difficult to say. So are we talking in the context of prophylaxis in high-risk patients, or are you talking
Yes.
about treatment in patients with
really both,
antibody reaction?
both models, but mainly prophylaxis.
So it's claimed that ATG has a beneficial effect in terms of promoting regulatory responses, in terms of the number of CD4, FOXP3 Tregs in patients. And in that context, I would see ECP supporting the action of ATG. Certainly, ATG may also have anti-regulatory effects, and what I wouldn't do is try and combine ECP with basiliximab, IL-2 blockade, because you would block the generation of regulatory T cells. And in the context of our cell therapy trials, the one difference between the control group and the cell therapy group in the background immunosuppression was the fact that we left out basiliximab in the cell therapy treated group because we thought that would have a detrimental effect on the regulatory T cells. So I think ECP could work in combination with ATG, but it's not something that's been tested.
Mm-hmm. And the second question is with respect to the time frame for using photopheresis. can we expect a similar efficacy if we use it in the first year, in the first months after transplantation, or in a longer period after the first year, or are there differences in the response?
So I think it depends on your reason for using ECP. So what excites me is the possibility that you could use ECP as a regulation-inducing therapy to reduce ultimately the long-term dependence of the patient on CNI. And I think in that case what we need to do is treat the patient intensively and early after transplant, before they've developed a T-cell response to the graft antigens, because you want their first exposure to graft antigens to be when the dendritic cells and macrophages that would activate the T cells have been modified by the photopheresis. So protocols that are being used at the moment, like the one in Vienna, is to use ECP as an add-on therapy for the first 3 months, and they have an intensive first 2 weeks, followed by 2 paired cycles twice a month for 3 months.
Congratulations. We need to, in order to treat ABMR, we need to remove the antibodies, and we know that we are not able to reach the bone marrow plasma cells. Do you have data in humans about the removal of these antibodies, of the donor-specific antibodies?
So it's very so yeah, in the context of heart and lung transplant, it's well published that if you have patients with circulating donor-specific antibody, and now also from kidney cohorts from Barcelona, that you can reduce the amount of circulating anti-donor antibody. You can't remove it. There's a level that remains, but you can reduce the quantity. And so, speaking speculatively, I think the way that we could be using ECP is that after you've treated the initial ABMR, you've done your immunoabsorption, maybe you've treated with rituximab, ECP might have a benefit in maintaining the absence of donor-specific antibody.
One more question. What do you think are the main reasons? Because this technique is not. We need randomized control trials to be comfortable with using the technique. What do you think that are the main reasons to not have this technique more used?
So, I mean, there are 2 main reasons, I guess. One is economic. So it is a sort of historical feature of the way that ECP has been introduced and developed. Transplantation was never a target, and transplant studies are always very expensive because you need very large numbers of patients to prove superiority, right? And the companies that have produced ECP devices in the past haven't sponsored large clinical trials, and I do agree that they're needed. So that sort of explains the absence of data. But I also think that, you know, as clinicians, we're skeptical about using any treatment when we don't really understand the immunological impact, right? And I think that's where the new new EU-funded consortium comes in. We do really need to get deeper down into these mechanisms so that we can have confidence that we're delivering ECP in the right way, in the most effective way. So the right number of cycles for the right length of time. Yeah. And that has to come, I think, before the very large clinical trials that would be, in general, practice changing.
Any other question? So what I guess is that the mechanism involved in this kind of regulatory or suppression induction are so complicated, and we don't have random trials, and we don't have even biomarkers to this. I mean companion diagnostics to decide when to go into the treatment or how to monitor, as Inigo said before, how to monitor with biomarkers we can use. But you are talking about cellular immunity, immune cells. So do you have any proposal from biomarkers to use before going into the treatment in ECP, and how to monitor them?
Yeah, I mean, sure, we have cellular markers that you can measure by flow cytometry. Of course, my interest is in the way that apoptotic cell material modifies monocytes, and that you can see those changes in peripheral blood after ECP therapy. So you get a shift in the phenotype of circulating monocytes that were never in the photopheresis. That's a measurable effect, but what we can't do at the moment is correlate that with a therapeutic benefit in transplant recipients, and that's why we need extra. But what I would say is I think there's now a very great interest in extracorporeal photopheresis in transplantation. It's growing very quickly, and I think we're going to see fast changes in this field in the very near future.
Okay, right. So any other question? If not, we can finish here. And anyone who wants to interact or to do some other questions, or just think on any collaboration with Hutchinson, please come here, and we can meet further during this morning. We have all the morning to join with any of you that are interested in collaborating. Thank you.